Welcome back to another student physical therapist video. And on this video, I'm going to be talking about all things radiating low back pain. And on this mind map here, I've outlined the 9 major causes or major things that can create radiating low back pain. And we're going to delve into each one of these. My name is Jim Hefner. I'm a physical therapist based out of Boulder, Colorado. I've been running the student physical therapist for, God, over 12 years now. So as you're watching this video, if you like it, please like, share, comment, subscribe. Tell me other things that you want to learn about because that's how we keep the ball rolling. So let's dive right into it. Radiating low back pain. Well, first of all, now being over 10 years out as a clinician, radiating low back pain no longer scares me like it used to. And the reason that is that one, if symptoms are radiating down into the legs, first of all, we know the nervous system's involved. So we know then we just need to start tailoring and targeting our interventions towards the nervous system. Um, at the heart of this is determining the cause of a patient's symptoms. So my approach to management of radiating low back pain is first determining the cause, second, determine based on what we're finding if they're appropriate for PT or not. Can we treat them or do we need to refer out? And then lastly, this education piece, the research backs it up, the clinical practice guidelines or clinical prediction rules back it up, that we've got to educate our patients. We need to teach them what's causing their pain from an anatomical cause, but we also need to teach them that from a neuroscience cause. So we need to kind of treat these things from the bottom up and from the top down. I'm going to switch over on the screen share here for just a second. And the first thing I want you to think about with radiating low back pain is the dermatomes and myotomes. So most often, if someone comes in and they have unilateral symptoms, we need to follow where their symptoms are running kind of along a dermatomal or myotomal chart. It's either going to be the dermatomes or myotomes, or it might be a peripheral nerve type of thing. But if it's coming from the low back, then we can assume that the spinal nerve root is involved. And if the nerve root is involved, then we can think about it from what's the associated muscular pattern or sensory motor loss that we're seeing from a dermatome, or the muscle weakness that we might be seeing from a myotomal pattern. With the dermatomes and myotomes, when we look at L1 is primarily going to be related with our iliopsoas muscle, so hip flexion. L2 is the sartorius muscle, which is another hip flexor. L3 adductors. L4 is going to be our quadriceps. So if you think someone's having irritation around the L4 area, maybe it's a disc herniation, then we need to check dermatomes, myotomes. We need to see how the L4 reflex or the patellar reflex is responding. But the symptoms that someone is having both in their back, but then the pattern of that peripherally, using the dermatomes and myotomes is a great way to draw symptoms back to their origin. So L4 is the quadriceps. L5, here we're getting into things like the tibialis anterior, extensor hallucis, extensor digitorum. We're starting to see some glute activation or glute issue stuff around L5. S1 is going to be glute med, glute min, glute max. S2 is going to be some more of the gluteal muscles, but then we're also going to be seeing foot intrinsic stuff like that. So the sciatic nerve runs from L4 to S3. And if any part of that is getting irritated, we're likely going to see some predictable symptomatic pattern down the leg. Now we know that the nerves can be finicky that way. So even if someone has irritation at L4 or 5, we might see a different part of the sciatic nerve down the chain feel that irritation as well. So it's not this black and white, but as a great starting point, identifying what the dermatomes and myotomes are can again help you draw symptoms from what's happening distally back to their proximal origin in the spine. So this is something that I show to patients quite a bit to help them relate why they might be feeling symptoms down in their foot, even though their back is causing it. It helps me from a diagnostic standpoint to know exactly what level of the spine could be irritated. I mean, the biggest thing is that from an education standpoint, it helps draw back why someone's symptoms are the way they are. So if there's tension or they're holding a lot of tone in the L5 nerve root, then we're likely going to see hypertonicity in the tibialis anterior and in the glutes. Hypertonicity, a lack of muscle activation, So depending on how they're presenting, it's going to show up in a variety of different ways. But again, I think this is off of Wikipedia, but know and understand the dermatomal and myotomal patterns because that'll help draw you back to the spinal nerve root level, which often will get you then to the cause of the low back pain. So let's go back to our mind map here. I'm going to reshare the screen. The different causes of radiating low back pain, they can be from a herniated disc degeneration, Facet syndrome, spinal stenosis, a spondylolisthesis, piriformis syndrome, and then the non-musculoskeletal things such as a tumor or an infection, and then lastly, a traumatic injury. Let's go left to right here. So when someone comes in with a herniated disc, most likely they're going to be in that 30 to 50-year-old range. And the reason is that in that age, the disc is still pliable enough where the inner gel-like substance still has more pliability or movement where it can get irritated. The discs often stiffen as someone gets older. So while they might lose some disc height, they're probably going to show up more as a degenerative discs or DDD as they get older. With a herniated disc, they're often having that dermatomal or myotomal pattern of symptoms. That means symptoms are going to be unilateral in nature. The disc, as it protrudes based on the biomechanics of the body, disc injuries typically happen in a flexion and or rotation type of position of the lumbar spine. So when someone comes in and they have a mechanism that matches a flexion-based injury, what we're thinking is we need to see to identify what level we're discussing in the lumbar spine. We need to see what the dermatome and myotomal pattern looks like. We can see a whole slew of symptoms with each one of these things. So if someone's coming in and they're having foot drop, well, that's going to be a significantly greater amount of disc herniation or irritation around the nerve root that's causing that sort of significant motor findings. Because it pushes posterior lateral, disc herniations are often unilateral in nature. As I mentioned a second ago, moving left to right here, degenerative disc disease, over time, the height of the discs between the spaces gets lesser and lesser. So that's why people often get a little bit shorter as they get older, because the height of each disc gets a little bit smaller. The facet joints come together, the foraminal spaces get closer and closer together. But with degenerative disc disease and a disc herniation, there's less space available for the nerve root, and as a result of that, either inflammation or direct compression on that nerve creates radiating pain down the legs. Next is facet joint syndrome. So in the first two, we're talking about the disc, which is the space between the facets. With facet syndrome, this is going to often be worse in extension and rotation positions. And as you can see here, when the facets come closer together, so in an extended position, it puts pressure on the cartilage and on the space between the facet joints. And as that happens, usually, in the cervical spine, they're known as Cloward's areas, where the symptom presentation is going to be down and laterally, down a few inches and laterally. It won't be quite as far down the leg as you'll see with a disc herniation. So in facet joint syndrome, because of that direct compression on the facet joints, the nociceptors and mechanoreceptors that are located in the cartilage that lines the facet joints, that's where we're going to see compression or tension there, which will then have some sort of radiating impact into the back. With all of these things, so with a disc herniation, a flexion-based injury is sort of what's causing the problem. So we need to do usually an extension-based treatment program. With facet joint syndrome, I don't necessarily say we need to do a flexion-based program, though. What we need to do is slow down the forces that are going through the facet joints. So I still am going to be working on extension positions, but we need to work on extension in a way that doesn't overload the facets. If someone is older and we're thinking some facet impingement, it could be that they have some degenerative disc disease, which then places their facet joints in somewhat of a closer or compromised position. The biggest thing with all of these, with the exception of the two on the right, is that we need to assess and monitor symptoms. We need to identify what vertebral level the symptoms are coming from. And then we need to start basically picking off symptoms and treating them as we go by. So we need someone to move into flexion and extension and rotation and side bending. So they must be able to do all those things at some point. It's just based on their irritability level. It sort of brings plausibility of why they're having that symptom, if we can understand what their mechanism of injury was, and then what structure we think is getting aggravated. So with Facet syndrome, we'll see the pain into the hip or the thighs. It's often worse in extension and rotation. It doesn't mean we shouldn't do those things. It just means that we have to grade those interventions accordingly. With spinal stenosis, there can be foraminal stenosis, which is when in between where the nerve roots exit on the sides right here, for example, that is the foraminal space. So we can have spinal stenosis laterally in the foramina, which is going to be our nerve roots again. So we'll see a predictable nerve root pattern there. Or it can be central stenosis. So if we do a cross-sectional area of the spine, if we're seeing a decrease of space in the spinal canal, that's where we'll see central stenosis. And central stenosis is more likely to have bilateral symptoms. They're more likely to feel symptoms into extension, and that's because in extension, the space in the spinal column gets a little bit reduced, whereas they might feel better in a flex position. There are, bike tests and flexion tests with walking that can help with the diagnosis of this. But what I think about is typically because of ligamentous thickening, age-related changes, we'll see more central spinal stenosis in older individuals. Spondylolisthesis. Okay, so real quick on spinal stenosis too. If it's foraminal stenosis, meaning it's the stenosis laterally, we're going to have more of unilateral symptoms with dermatomes and myotomes. If it's central canal stenosis, we'll likely see bilateral symptom. We might still see unilateral, but we're more likely to see bilateral symptoms, which then it just is it doesn't really change our treatment protocol unless it's severe spinal canal stenosis, which means they might need a decompression or some sort of surgical intervention. But overall, the location of stenosis should help guide what your treatment program or protocol is going to look like, and it should guide you from a diagnostic standpoint. Spondylolisthesis is any slippage of the vertebrae. So that can be anterior, posterior, lateral slippage. What we think of most commonly with spondylolisthesis is the anterior slippage of the superior vertebrae relative to the inferior one. The one that we most commonly think about with spondylolisthesis is your young gymnast who's hyperflexible, who's loading into extension excessively. And what that does is it can often create a pars interarticularis fracture because of that constant extension loading based positions. Now, with spondylolisthesis, the most common type is the isthmic one, and that means isthmic means narrowing of the connection between two places. So when you're thinking about spondylolisthesis, it doesn't always mean that there's going to be a pars interarticularis fracture. Oftentimes on MRIs in older individuals, we'll see a mild anterolisthesis or mild retrolisthesis. And those things just say that there's relative movement of the vertebrae relative to the one below it. And so that slippage is then we have to determine if we can treat that or if we need to refer out. Most likely, if we're not seeing any acute fractures and based on the MRI findings, if that slippage is only mild or moderate, then we need to go back to our principles of core strengthening, discussing what's aggravating and alleviating their symptoms, and more of our standard conservative approach. With piriformis syndrome, the piriformis is located in the posterior gluteal region. Because of its location, the sciatic nerve can either run directly through that muscle or it's located very close to that muscle. And because of that, the piriformis can cause radiating symptoms down the leg. They won't often have that lumbar type of low back pain, although they might just from again a nerve irritation type of thing. But most likely they're going to have deep gluteal pain with potential referral down into the back of the hamstrings. The piriformis muscle runs from the pelvic surface of the sacrum, so the anterior side of the sacrum, to the superior portion of the greater trochanter. And it is a hip external rotator primarily. It abducts the hip slightly. And if you're sitting for long periods of time, or if you're doing a lot of exercise, hip rotation type of exercises, or having to control hip rotation, the piriformis can get inflamed or aggravated, which can then put pressure on the underlying sciatic nerve, which can lead to radiating low back pain. So the various causes of that one would be the direct compression of the sciatic nerve from the piriformis. Last two would be things like a tumor or tumor infection or trauma. And with a tumor or infection, it's going to be an inflammation or a direct compression if it's a tumor onto the nerve space, and that can create radiating low back pain. These people are likely going to have persistent pain with some systemic symptoms. So if someone comes in and you're suspecting that they might have osteomyelitis or they might have an osteosarcoma, you need to ask about prior history of cancer, weight loss or weight gain, any recent fever or night sweats. Those systemic signs and symptoms are what's going to help guide you to, and the persistent nature of their symptoms. With the things that are on the left-hand column of the mind map, we can usually change that with changing the movement and changing the position. With a tumor or infection, they're going to have persistent symptoms regardless of what position they're in. And that's where you need to start referring out or recommending imaging, something to get more information about what's driving or causing their symptoms. Lastly here, trauma can be like a fracture to the spine, a fracture to the ligaments of the spine, dislocations. And with that, there's gonna be some acute mechanism of injury, and then they might have some possible spinal instability. For traumatic injuries, I recommend referring out for imaging as well, because then we can get a more detailed approach of what's happening on the tissue level, how much rest, modification, or maybe surgical intervention they might need. All of these things, herniated discs, Facet syndrome, spinal stenosis, spondylolisthesis, piriformis syndrome, they all can create radiating symptoms down the leg. Our treatment approach needs to be identifying what aggravates and alleviates symptoms, identifying what the mechanism of injury is, identifying the patient demographics, because that's going to cue us into what structure is involved. And knowing what structure is involved can help then on your diagnosis and prognosis about how long it's going to take for that person to get better. But for me, it's really identifying the symptoms around what's causing their pain, and then also educating them about how pain operates in the body and then the top-down nature of pain. But all of these things are the various causes of radiating low back pain. So when someone comes into the clinic, you should be thinking, is it a unilateral or bilateral pattern? Is this something that I can treat? Is this something that changing positions alleviates their symptoms? And when you start asking yourself those questions, then you can build a pattern around their symptoms to then give them the best, most appropriate plan of care.